I'm Dr. Deb Ehrlich, a physician in the Department of Family Medicine at Tufts University School of Medicine, and I'm joined by my chair, Dr. Wayne Altman, in the Department of Family Medicine.
So we're coming to you to make a video about telemedicine. Telemedicine is sometimes called telehealth. Sometimes it's called virtual visits. It means lots of different things. It can mean having a video visit with a patient. It can mean having a telephone encounter with a patient. It also could mean even having an electronic encounter with a patient.
We doctors did not invent this concept of virtual care. Other professions, therapists, social workers, psychologists especially, have long provided therapy via video platforms. Other professions besides the healthcare field, like business and the corporate world, have long used video conferencing for decades to communicate with partners and clients around the world without getting on an airplane. So we're not the inventors of this.
Yeah, embarrassingly, medicine has lagged quite far behind on this one, and you know, we only got paid if our patients came in to see us in person. Even if we were going to do an encounter with a patient that did not involve any physical exam, didn't matter. Historically, we didn't get paid unless we saw them in person, and that's, I think, why we've lagged behind.
Sure. Interestingly, the pandemic has forced our medical profession to quickly pivot, and now we're offering telemedicine for patients across the board in all sorts of fields and specialties. It was facilitated in March of 2020 when Medicare very swiftly and decisively authorized payments for these video visits and telephone visits, and they are reimbursing video visits at nearly the same rate as in-person visits, and telephone visits are around a quarter or a third of the in-person rate. Now, at this point in the pandemic, many doctors are doing some or most of their visits virtually, often from home, which is especially useful if the doctor herself has to be quarantined or isolated and can't go into the office. And my system very, very quickly implemented a telemedicine program last month.
I'm in a private practice, which is affiliated with systems, but we kind of changed on a dime. One week we were seeing patients, and the next week our door was locked, and any patient who came had to knock on the door, which was bizarre, to enter our office. The reason being is the previous Friday, a patient who was actively coughing and sick walked in the office and said, "Can somebody treat me?" and had no protective equipment on, and I think our front desk had collective heart attacks at that moment. So our office manager instantly created a new system in our office where the door was locked. And in the next week, it was almost all telehealth for our patients. And so, you know, the world is changing so quickly. And I think it's important to let you all know that we are making this video on April 20th, 2020. Things may be a little bit different in a variety of ways when you watch this video. I'll say for myself, in the last month, 95% of my visits have been over the phone or through video, and they're rapidly switching to more and more video. I have to say, when I have video visits, I find them more satisfying than the phone visits. It feels more therapeutic. It feels more like you've helped the person. It feels like there's a greater connection. And so that's been rewarding. I'm seeing probably about on average one person a day, often a child less than 1 year old who needs their vaccinations, or it could be an adult who has extenuating circumstances that require that they be seen in person. Are you around the same level of patients, Dr.
About
Ehrlich?
that, yeah. Like 95% is virtual at this point, probably one per session. So a lot of visits can be done virtually. Any visit that's 100% discussion is a great candidate for a telemedicine visit, right? Like a mental health visit, for example, a follow-up discussion on depression, where I just prescribed an antidepressant last time, and the follow-up visit just needs the integral history. How's that medication been helping you? Have you started therapy? Has the medicine helped? Are there any side effects? I can administer that patient health questionnaire, that depression screener and follow-up instrument on video or on the phone, and get a numerical symptom score. So that's a great candidate for doing a visit virtually like this. And then medical visits are also very appropriate. They can include the chronic disease management visits, like a conversation with a patient. Recently, I had a conversation about an endoscopy result and what medications a patient should start for her ulcer. And that's a great candidate for this kind of visit where an exam isn't needed. or a blood pressure follow-up visit. We've been sending a lot of blood pressure cuff prescriptions to patients and sending them ambulatory cuffs so they can measure their blood pressures at home, save them the visit, we get the numbers, and we can adjust medications virtually. So a little bit of a silver lining there is that patients can actually be a little bit more active agents in their own health by taking their own blood pressure readings. And diabetes visits, another great source of telemed visits for us.
On the Tufts mobile Medicards is a handout called the Diabetes Rule of Threes that some of you have seen before. And if you think about the Diabetes Rule of Threes, you can accomplish a great deal of that virtually. You can check to see when their last visit with the eye doctor was. You can order blood work and testing like a random urine for microalbumin and a BMP to check their kidneys. You can refill their ACE inhibitor. You can inspire them to do a good foot check on a video visit. You can even look at their feet. How charming to look at somebody's feet on a video visit. You can check on their medications. You can do robust nutrition and exercise counseling. You can check on their metformin and other diabetes medications, their cholesterol medication, their blood pressure medications, and smoking cessation counseling if need be. And so there's all of these things in a chronic disease context can be done virtually.
Sure. So what you're saying is that chronic disease management is mostly discussion. It's mostly counseling and motivational interviewing and assessment of where the patient is and inspiration and prescription management. So most of that can easily be done virtually. There are also acute concerns that we can handle. I've been doing a lot of these on video: diagnosis and management of a new rash or conjunctivitis or cellulitis. Even musculoskeletal concerns can be examined by video. I've had a couple of patients demonstrate their shoulder range of motion for me on the video, and there are a lot of things we can glean by seeing them that way. Telephone's a bit harder for those, but there are certainly exams that you can do on the phone too, like respiratory exam, to hear how short of breath the patient is. Can she speak in full sentences? Is she struggling? That kind of thing. I have diagnosed a lot of COVID-19 via video. I've gotten really good at that particular one. But URI, flu, cough can all be managed virtually too. And there are actually officially 7 parts of the physical exam that you can do with your eyes only on video. And then a few more you can do with the patient's help, like ask the patient to grab a flashlight and shine the light into her own oropharynx, or do pupillary dilation, and help us out a little bit on the exam. So, it takes a little creativity here, but there's a lot we can do virtually for them.
I think the challenge of this creativity has been a little bit fun to try and figure out how we can help people in this new world that we're in. Mm-hmm. And you were talking about, Dr. Ehrlich, diagnosing COVID-19 on a video visit. I've had the same experience. I feel like people will kind of put their hands on their chest and kind of indicate, I'm just having a hard time kind of catching my breath and kind of getting breath here. And it's so interesting how when you see enough people, you start to see people use the same body language to describe their symptoms. And what else is interesting is that our patients are absolutely loving the convenience of telemedicine. Turns out people didn't like taking out a half day of work to make an appointment, come park and get into the office and wait and do all of the things that are necessary for an in-person visit. And I think medicine was really lagging behind in that way, meeting people's needs and meeting people's convenience. And when we're done with this pandemic, I'm pretty sure that we will have learned a lot of lessons about how to be more patient-centered and meet patients' needs better.
I've seen the same thing. I completely agree. I've seen babies under 2 months old via telehealth, and they have a lot of frequent visits. I have parents weighing their babies at home on a baby scale that we've obtained for them, and they report their usual interval history, how nursing is going and how the baby looks. And I've looked at the umbilicus healing in the newborn period on video, and we can do all the anticipatory guidance on video, some of the physical exam too. And it's such a gift to these tired parents. They don't have to trek out of their house. Forget COVID-19. This newborn's at risk for so many other infectious diseases that they're really protecting their baby from. So it's been a real gift for these patients as well. And then I'm thinking on the other end of the lifespan, I have these two elderly sisters who live together. They're both wheelchair bound, and coming to see me, which they do quite often because they both are quite ill and have a lot of chronic diseases, it's been a real challenge. They have to order the ride, the PT1, to get them into the office, and it's a big hassle. It takes at least half a day every time we have one measly follow-up appointment. So I've been able to do virtual visits with them, and it has just been such a time saver. We've been preserving everybody's safety, mine and theirs, and it's been much more convenient for everybody. It's been a complete game changer.
So what circumstances would you say that you're avoiding a telehealth visit and actually asking the patient to come in to be seen?
Well, it makes sense that patients who need an exam for appropriate management, they'd have to come in. Someone who needs an abdominal exam, a pelvic exam, even an otoscopic exam to look in the ears, even if it's a quick thing that needs to be in person, that's not suitable for telehealth. They have to come in. And then, of course, procedures, IUD removals, wound care, incision and drainage, that kind of thing, of course, has to be done in person. So then we make proper arrangements. If it's a child, we say just one parent can come. We ensure everybody has a mask and protective equipment. Our staff does these virtual screenings by phone right before the appointment, just to make sure the patient doesn't have a new cough and fever before coming in, so everyone's safe.
Yeah, I mean, we're overall, we're painting a pretty rosy picture of telehealth and all the things that we're doing for patients, and it kind of begs the question, well, what took us so long? Why weren't we doing this in the first place and meeting our patients' needs and making life more convenient for them? I guess there were a few barriers to this.
You make a great point. The big one's money, right? The top three, money, money, money. We haven't been paid for these visits. And so the system hasn't been set up. We've not been incentivized as individual docs, but more as the system to accommodate these kinds of telephonic, email, or video visits. And doctors have been doing some of these things, but out of the kind of goodness of their own hearts on their own time, they'll call patients back without being paid. So that's probably been the biggest barrier. But more specifically, look, you need leadership support. You need the physicians to be properly trained in how to document, how to bill appropriately so that the insurers do reimburse us for these reimbursable visits. You need a lot of IT support to make sure that everybody has a webcam and a microphone and all these hardware and software. The organization has to contract with some kind of software package, whether it's Zoom or some other video conferencing device that the organization's okay with. And so there are those kind of systems barriers have long been the main issue, and no one has bothered putting them in place, I think, because we weren't getting reimbursed. That's my thought.
Yeah, so I think that it was just starting to happen. There were a handful of doctors who were starting to contract with HIPAA compliant platforms and video visits were starting to get paid for, but it was really only a handful of people, and there was some expense involved in finding a HIPAA compliant platform and setting it up for the whole office. And interestingly, in response to this pandemic, the HIPAA compliance around these video platforms was waived. And so now you have doctors who are FaceTiming patients, which is certainly not HIPAA compliant. And, the greater good has been prioritized, that we need to help people, reach people, and care for people, and which doesn't take away the need to consent your patients. You do need to make sure that they understand that the platform you're using is not secure, and that they are consenting to having a video visit over a non-HIPAA compliant platform. But I have yet to have a patient push back about that, and we certainly don't need signed written consent.
Sure. So pre-COVID-19, it was required that the platform had to be HIPAA compliant with end-to-end encryption. And now that's been temporarily waived. No doubt after this pandemic, it will be back in place. So encrypted secure platforms are still best. My organization does use one. But in these changing times, as a temporary measure, it's certainly acceptable to use some other platforms, as you mentioned, like FaceTime and others. There is the issue of billing. Patients should be aware that a copay might be charged if we are billing the insurance company. At the moment, most of the insurance are not charging patients any cost sharing, any copays, or any bills at all. But that is likely to change after this pandemic subsides. So in my typical consent process, I'll verify the patient name and date of birth. I'll introduce myself. I'll introduce my scribe. We should talk about scribes too today. And I'll ask if anyone else is in the room with the patient. And then I'll tell patients, look, even though I'm trying to approximate a live visit here, it's not guaranteed. It's not completely equal to being in person, but I'll do my best. So that's how I handle the consent.
Yeah, so you mentioned scribes. I have a medical scribe who sometimes she'll actually come to my home and wear a mask and scribe from there. Although I'm considering maybe doing these visits by Zoom and having the three of us on the line.
So now we are doing a Zoom-like meeting with myself, the patient, and the scribe. So there are three little boxes on the screen. And my scribe and I are never together physically. We're always virtually connected, whether I'm at home or at work, like I am today. So the scribe is doing the three-way call. And on the phone calls, the scribe is joining me on the three-way phone call too. So she can participate no matter where she is.
So telehealth is clearly increasing patient access to healthcare, which is critically important, and it is so important. Primary care is such an important part of managing this pandemic, because one of our jobs is to manage all of the acute and chronic illness and keep our patients healthy and keep them out of the emergency department and out of the hospital, especially when they don't need to be there, which is so often the case.
You make such a great point. I think from a systems perspective, telehealth allows patients to save their in-person visits for the truly necessary times, whether it's our office or emergency settings or other places. And they're freeing us up to see the live patients when that's needed, but still address everybody else's needs in real time from home. So look, even though our healthcare system is new to widespread telemedicine, I think it has amazing potential to dramatically reallocate resources to where they're really needed. It'll open up our schedules. It'll give patients access to our schedules more quickly. It'll decrease patient wait times. And overall, it should conserve all our resources.
So a huge part of my practice, one of my favorite parts of my practice are group visits. Mm-hmm. And we were in the middle of a 15-session group visit in March when the pandemic began. And of course, the pandemic began before that, but when we realized the pandemic was beginning. And I was worried, what are we going to do? And we started using a conference call line at the beginning, but we quickly converted to Zoom. And the patients absolutely love it. We're meeting their kids, we're meeting their pets. They're walking out in their neighborhood while they're on the visit. And they've begged us to continue the group visits long past when the session was going to be over, because they're so isolated and lonely, and they just love being with each other. And it's been such a success. We have another group visit, relationship groups, where we have couples who come together, and it had not started. And we emailed them and said, I guess we're going to have to postpone this because of the pandemic. And they said, actually, we're cooped up in our house with each other all day, every day. We really kind of need this now more than ever. Could we please do this by video visit? And we said, sure. And it's been spectacular. It's been so useful for the couples. So I've loved using virtual visits with the group setting.
That sounds like telehealth 2.0. So my organization has already started the next stage, maybe it's 3.0, which is targeted outreach. So I actually receive a weekly list of patients curated from my panel who are considered high risk. So it's everything from pregnant patients, people with mental health issues, people with complicated medication regimens or other high risk situations. And then my medical assistant will outreach to them. They use a standard checklist, like, do you have access to a thermometer? Do you know how to get your medications? Do you have groceries? Do you feel like you might get sick? What are you worried about? There's a whole list of questions she asks. And then a lot of these outreaches actually result in booking a visit on telehealth, either video or telephone. We're also now supposed to outreach to all of our elderly patients to make sure our advanced care planning is up to date. What about you, Dr. Altman?
Well, so we have recruited a group of 23rd and 4th year Tufts medical students who as of today, literally today, just got access to our Epic electronic health record, and are going to be outreaching to populations, elderly patients, to talk to them about both the social isolation of home quarantine and advanced care planning. And also our patients with a history of mental illness, and kind of reaching out to see how they're doing. And then hopefully they'll do some counseling and have therapeutic conversations with them, and then connect them back for some virtual visits to kind of continue the conversations. It's interesting. I have been involved in some advocacy efforts around telehealth. The genie is out of the bottle for telehealth. And so I think the powers that be are not going to be able to say to doctors, you can't get paid to have video visits with patients anymore. I think that's over now. And so we are working in a variety of ways. I was speaking with a state senator in Massachusetts with whom I have a relationship, and she was talking about how she's been advocating and has written a bill that she's been pushing for the last 2 years around telehealth, and it was still struggling to get the support it needed to pass. And then in 1 week's time, the governor issued an executive order, and then that was that. Now, that executive order may get lifted, or the state of emergency hopefully will get lifted someday soon. And that's where we need to kind of pick up and see where this takes us. But it's very clear that this crisis, while generating some unspeakable tragedy for lots of individuals and families, is also creating some opportunities for our healthcare system to evolve.
Absolutely. Well, it's been great chatting with you. We've talked a lot about telemedicine. We talked about indications, the kinds of visits that we can do on virtual visit platforms. We've talked about the barriers, the contraindications for using them. And we talked about some of the features in health systems in general that facilitate telemedicine and some of the consent processes as well. We've talked a little bit about why historically medicine hasn't gotten around to offering these for patients, and why this pandemic has unfortunately been a catalyst to have us move forward in telemedicine. So I agree with you. I think this has been a tremendous crisis all over the planet. It's reached every corner of the world. It has caused economic effects, untold deaths and tragedies and illnesses, stresses on the healthcare systems, mental health issues, and so many terrible consequences that hopefully we'll be more prepared to deal with next time we have a pandemic. But there is a silver lining here, and just specifically on the topic of today, the silver lining of this conversation is telemedicine. I think it has real potential to transform our whole healthcare system in the 21st century. It's great for patients, it's great for families, and it's been tremendous for doctors and the rest of our healthcare team. So I look forward to seeing where this goes after the pandemic subsides, and how it will enhance, not replace entirely our in-person visits, but how it will enhance what we do for patients day to day.